Bismillahirrahmanirrahim. Assalamu alaikum. Assalatu wassalamu ala khatamin nabiyyin. Dear colleagues, I welcome all of you to this session on diabetes in Ramadan. I am Dr. Aisha Sheikh, consultant endocrinologist. I am associated with Khan University Hospital, Medical Institute of Diabetes and Endocrinology and Metabolism, and University of South Wales, UK as their faculty member. Fasting during Ramadan is obligatory for all adult Muslims, but Allah subhanahu wa ta'ala has exempted travelers and people who have illnesses from these obligatory fasts. According to EPIDIAR study, 79% of type 2 diabetes patients and 43% with type 1 diabetes fast at least for 15 days during Ramadan. The CREATE study further showed that 94.2% of Muslims with type 2 diabetes fasting during Ramadan, and out of these, majority were fasting for the whole month of Ramadan. This is the mean continuous glucose monitoring profile from healthy subjects before Ramadan, shown by blue line, and during Ramadan, shown by red line. You can see that there is a remarkable stability of blood glucose during fasting hours, followed by a minimal rise in blood glucose at iftar, still staying within the normal range throughout the fasting hours. However, in a patient with diabetes who is fasting, there is a risk of blood glucose going low before iftar time and rising rapidly after iftar time. There are risks associated with fasting in patients with diabetes. The risk of hypoglycemia increases by 4 to 7 folds, both in type 1 and type 2 diabetes. The risk of hyperglycemia increases by 3 to 5 folds, and the risk of diabetic ketoacidosis, dehydration, especially during summer season, and thrombosis is there. There are risks associated with fasting in patients with diabetes. The risk of hypoglycemia increases by 4 to 7 folds, both in type 1 and type 2 diabetes. The risk of hyperglycemia increases by 3 to 5 folds, and the risk of diabetic ketoacidosis, dehydration, especially during summer season, and thrombosis is there. Thus, the experts from IDF Diabetes and Ramadan group have emphasized that 6 key areas should be focused as pre-Ramadan diabetes education. These include risk quantification, emphasizing the need of blood glucose monitoring during Ramadan, fluids and dietary advice, exercise advice, medication adjustment, and all the more important, when to break the fast. As your patient's healthcare provider, you have to risk quantify them depending upon following factors: the type of diabetes, whether it's type 1 or type 2 diabetes, patient medications, whether there are any medications that predispose to hypoglycemia, individual hypoglycemic risk, presence or absence of complications and or comorbidities, the individual's social and work circumstances, and Ramadan experience in the last year. Teaching your patients to break the fast during hypoglycemia to preserve life is very important, because data suggest that majority of patients might not be opting to break the fast during hypoglycemia. So besides risk categorization, you will create an individualized management plan for your patients that will include medication adjustments and advice on self-management, including not only self-monitoring of blood glucose, but also using that data to modify their insulin doses if needed. During Ramadan, the patients have to adhere to the nutrition and medication dose adjustments plan that you gave and continue doing their self-monitoring of blood glucose. They can contact you if and when needed. After Ramadan, when they come for their follow-up, you have to discuss the medication regime readjustments with them. So the question comes, when to monitor their blood glucose during Ramadan fasting. Generally, patients who are on insulin treatment would require more frequent testing of their blood glucose compared to someone who is on oral antidiabetic agents with less potential to cause hypoglycemia. Generally, it is recommended that patients should be testing their blood glucose before Sahar meal, 2 hours after Sahar meal, at midday, in the mid-afternoon, just before iftar time, and 2 hours after iftar time. In addition to these timings, they should be testing whenever they feel symptoms of hypoglycemia. It is essential to adhere to a Ramadan nutrition plan that will divide adequate amount of calories between Sahur meal, Iftar meal, and if necessary, 1 to 2 snacks. Sugar-heavy desserts have to be avoided, and instead, a low glycemic index, high fiber carbohydrate meal is preferred. Hydration needs to be maintained between meals by drinking water and non-sweetened beverages. Sahur should be taken as late as possible, and adequate amount of proteins and fats should be consumed in the Sahur meal to induce satiety. Similarly, iftar should begin with water to rehydrate and with 1 to 2 dates to raise blood glucose levels. And between iftar time and the Sahur meal time, low-calorie snacks such as fruit, nuts, and vegetables can be consumed. This is the Ramadan food plate, through which you can teach your patients how to divide different food groups for their plate. This is going to induce satiety without causing much fluctuations in the blood glucose levels, and at the same time providing adequate calories from different food groups. According to IDF-DAR guidance, patients can be divided into 3 risk categories. The category 1 is very high risk category that have patients with characteristics that puts them at a very high risk of complications if they choose to fast. These patients' characteristics include severe hypoglycemia, diabetic ketoacidosis, or hyperosmolar hyperglycemic coma within 3 months prior to Ramadan. Similarly, history of recurrent hypoglycemia or history of hypoglycemia unawareness fall into this risk category. Patients with poorly controlled type 1 diabetes, any patient with diabetes who develops an acute illness during Ramadan, women who are pregnant with pre-existing diabetes or have gestational diabetes mellitus who are treated with insulin or sulfonylureas. Similarly, patients who are on chronic dialysis or have CKD stage 4 and 5. Patients with advanced macrovascular complications, similarly old age patients with ill health, all fall into this risk category, and they should listen to medical advice and must not fast. The second category is the high-risk group that includes one or more of the following: type 2 diabetes with sustained poor glycemic control, well-controlled type 1 diabetes, well-controlled type 2 diabetes who are on multiple daily insulin or mixed insulin, pregnant women with diabetes or GDM who are controlled on diet only or metformin. Similarly, patients who have CKD stage 3, those who have stable macrovascular complications, patients with comorbid conditions that present additional risk factors, and people with diabetes performing intense physical labor, treatment with drugs that may affect cognitive function. An important issue rises if the patients who are falling in very high risk or high risk category who were advised against fasting by their healthcare provider still insist to fast. In that situation, they should receive structured education. They should be followed by a qualified diabetes team, should be testing their blood glucose very frequently, and adjust their medications according to recommendations given by their healthcare provider. At the same time, they should be prepared to break the fast in case of hypo or hyperglycemia, and should be prepared to discontinue further fasting in case of frequent hypo or hyperglycemic episodes, or if there is any worsening of their related medical conditions. The last category is labeled as moderate or low risk category. These patients can fast and they should receive structured education, should check their blood glucose regularly, and adjust medication dose as per recommendations. So you can see that patients well controlled type 2 diabetes treated with one or more of the following are included in this risk category. These are the patients who are either controlled or lifestyle modification, receiving metformin, acarbose, thiazolidinediones, second generation sulfonylureas, incretin-based therapy, SGLT2 inhibitors, or basal insulin. A very important advice to all your patients with type 2 or type 1 diabetes who choose to fast is about when to break the fast. And this should include that all patients should break their fast if their blood glucose falls below 70 milligram per deciliter during fasting duration, because continuing fast in such a situation can further lower their blood glucose and put them at risk of severe hypoglycemia. Similarly, if the blood glucose goes above 300 milligram per deciliter, they have to break their fast and treat that hyperglycemia. In addition, If they have any symptoms of hypoglycemia and are unable to check, but they know that they are hypoglycemic, they should break the fast. Similarly, if they are having features of hyperglycemia, dehydration, or if they fall acutely ill during fasting duration, they should break their fast, because in all these situations, continuing fast will pose a threat to their lives. And it is important that you advise your patients that if they break the fast in such a situation to treat the medical condition, then the penalty is just to keep one fast after Ramadan ends. The pre-Ramadan assessment and risk stratification should begin at least within 6 to 8 weeks prior to Ramadan. At that time, the healthcare provider can take a detailed history, share the patient experience during previous Ramadan, and the patient's ability to self-manage their diabetes. And then structured education, as we already discussed, includes role of self-monitoring of blood glucose, when to break the fast, when to exercise, fluids and meal planning, and medication adjustments during fasting. Those patients who are having moderate or low risk category and are allowed to fast should continue to do at least 1 to 2 times their monitoring of blood glucose during day. But those patients who fall into high risk or very high risk category but still choose to fast, as you already discussed, they have to test their blood glucose very frequently. And we have already discussed when to break their fast. Let's discuss how to modify doses of anti-diabetic medications during Ramadan. Patients who were on metformin once daily before Ramadan will take their dose at iftar time. Patients who were on metformin twice daily will take one dose at seher time and this next dose at iftar time. Patients who were on 3 times daily metformin will take the morning dose at seher time and will combine the afternoon and the evening dose to be taken at iftar time. Patients who are on modified release or prolonged release metformin do not need any dose modification, but the dose has to be taken at iftar time. No dose modification is required if the patient is taking acarbose or pioglitazone, because the risk of hypoglycemia is very low and these can be taken either with iftar or at sahur time. For short-acting insulin secretagogues like repaglinide, the doses may be reduced or redistributed to 2 doses during Ramadan according to the meal size. Similarly, the DPP-4 inhibitors do not require treatment modifications or dose adjustments during Ramadan. The SGLT2 inhibitors can be used with caution in some patients, especially remember that if the patient is working in hot environment, you should stop their SGLT2 inhibitors during Ramadan. But for all others, no dose adjustment is required and they should be advised to take their dose at iftar time. For long-acting GLP-1 receptor analogs, usually if their dose titration was already done 6 weeks prior to Ramadan, no further treatment modifications are required and they can be taken at sahur time. Since sulfonylureas pose a risk of hypoglycemia, their dose modification is much needed during Ramadan. If they were taking once daily dose of sulfonylurea, that has to be taken at iftar time. And on those patients who were already well controlled on the certain dose of sulfonylureas, their dose must be reduced. For those patients who are taking twice daily sulfonylureas, the iftar dose remains the same, but in well-controlled patients, the sahur dose need to be reduced to almost half. With older classes of sulfonylureas like glibenclamide that carries a higher risk of hypoglycemia, those should be avoided during Ramadan. Rather, second-generation sulfonylureas like gliclazide or glimepiride should be used in preference over the older generation ones. Let's move on to insulin dose adjustment during Ramadan fasting for insulin-treated patients with type 2 diabetes mellitus. If the patient is taking basal insulin in the form of either NPH, detamers, or glargine, then its dose has to be reduced by 15 to 30% and has to be taken at iftar time if the dosing was just a once daily dose. However, if the patient was taking twice daily insulin as a basal insulin, then they have to switch their morning dose to the iftar time and take the evening dose at seher time after reducing it by 50%. Coming to the postprandial control through short-acting insulin, they have to take the normal evening dose or the dinner dose at iftar time. Obviously, the lunchtime dose will be omitted, and the morning dose has to be reduced by 25 to 50% at the Sahar time. In this slide below, you can see the table that guides you in adjustment of further insulin doses according to their self-monitored blood glucose. If the insulin-treated type 2 diabetes patient is taking pre-mixed insulin, then how to adjust that insulin during fasting in Ramadan? If the patient is taking once daily dose, that once daily dose goes at the iftar time in the usual dose. If the patient is taking twice daily dose, then they have to take the normal dose at iftar and reduce the sahur dose by 25 to 50%. If the patient is taking 3 times daily dosing, then they have to omit the afternoon dose and you have to adjust their iftar and sahur doses and carry out dose titration every third day according to that table given below, which will help you guide how the doses can be adjusted according to their self-monitored blood glucose. For patients with type 1 diabetes who are on multiple daily insulin doses, how to adjust their insulin doses during Ramadan. So their basal insulin, which is either the long-acting insulin or the intermittent-acting insulin, has to be taken at iftar time, and we have to reduce their dose by 30 to 40% to avoid hypoglycemias at the pre-iftar time. Similarly, their short-acting insulin that covers their bolus requirements or the prandial insulin, the normal dose is taken at iftar time, and the sahur dose has to be reduced by 25 to 50%. Similar to what we earlier saw in type 2 diabetes mellitus insulin-treated patients, further dose adjustments would be required depending upon their self-monitored blood glucose values. With the current COVID-19 pandemic, the human race is going through one of the toughest phases of its existence. For our patients with diabetes, the principles of diabetes management stay the same, that is, adhering to lifestyle modification, taking their medications on time, and monitoring their blood glucose, and trying to keep their blood glucose within normal ranges. The general principles of prevention of COVID-19 pandemic, as are recommended by different societies and the WHO, should be practiced and adhered by patients with diabetes as well. However, in the event of an infection, if the infection is mild, they should increase their monitoring of blood glucose because that might necessitate an increment in their medications and insulin requirements. So that should be done accordingly with the help of an aid of their healthcare provider as well. However, the SGLT2 inhibitors, because we want to stop those agents during any infection or illness, have to be stopped. God forbid, if the infection progresses to a critical phase and requires hospitalization, then the inpatient hyperglycemia management that is done through insulin management should be practiced for diabetes management rather than using any of the oral agents during critical illness. Thank you for your participation in this educational activity, and please stay safe. And I'm grateful to Guest Pharma for making it possible to reach out to you with this important presentation. Thank you very much.